Welcome. Today I shall discuss the diagnosis of rheumatoid arthritis. To diagnose a case, we need some investigations. Similarly, for the rheumatoid arthritis, we need some tests like hematology test, where the complete blood count may show normocytic, normochromic type of anemia. CRP and ESR may remain high. Serology test, rheumatoid factor, and anti-cyclic cytorenated peptide antibody. These two are important serologic tests for rheumatoid arthritis. Regarding rheumatoid factor, it has low sensitivity and low specificity. Sensitivity 75 to 80%, meaning 20 to 25% false negative result, and this may be explained due to the fact that 20 to 25% of rheumatoid arthritis are seronegative. Specificity 75 to 80%, meaning 20 to 25% of results are false positive, which may be explained due to the positive rheumatoid factor in other connective tissue disorder as SLE, primary Sjogren syndrome, or in subacute bacterial endocarditis, hepatitis B, C, even 1 to 5% of normal healthy people. Now discuss about the anti-cyclic cytorenated peptide antibody, that is anti-CCP. It has low sensitivity but high specificity. Low sensitivity can be explained due to 20% of the seronegative RA, specificity 93 to 95%, meaning only 5 to 7% of the results are false positive. So combined use of RA and anti-CCP may reach the sensitivity up to 80%. So one can conclude that from serology test, rheumatoid factor and anticyclic cytorenated peptide help us for detection of rheumatoid arthritis. Synovial fluid analysis. Synovial fluid white blood cell count in rheumatoid arthritis patient usually 5,000 to 50,000 per cc, whereas it is less than 2,000 in non-inflammatory arthritis cases. Regarding joint X-ray, early stage may show periarticular soft tissue swelling and juxta-articular osteopenia. In advanced stage, diminution of joint space shadow with bone erosion. Late stage may show dislocation, deformity, ankylosis, and osteoporosis. X-ray, here we can see the soft tissue swelling in the early stage. In later stage, decreased joint space shadow and bone erosion. MRI scan of bones and joint may show marrow edema and early joint fluid detection. Ultrasonography scan with power Doppler study of joint usually show high vascularity in synovial membrane and surrounding soft tissue with low resistance index, usually less than 0.8. HRCT scan thorax, as we know, as a extraarticular manifestation of rheumatoid arthritis, pulmonary complication. Three common pathologies are pruritus or pleural pulmonary nodule, and interstitial lung disease. Let us see pleural left-sided here, pulmonary nodules, interstitial lung disease. Here it is usual interstitial pneumonia pattern presented as honeycombing with reticulation, and next ILD pattern is NSIP pattern or non-specific interstitial pneumonia pattern, which is commonly presented as ground glass opacity in CT picture. So here we see in interstitial lung disease, two common patterns are UIP pattern presented as honeycombing with reticulation. Number two, NSIP pattern presented as ground glass opacity in CT picture. Finally, we have to conclude and we have to diagnose a case for rheumatoid arthritis, and depending upon the 2010 American College of Rheumatology Euler scoring system, we have to depend upon four parameters: joint involvement, serology, acute phase reactant, and duration of symptom. Depending upon the four parameters, we have scored, and if the score is 6 or more, it is a definite case of rheumatoid arthritis. And this scoring system is particularly important for the early joint involvement in rheumatoid arthritis when one or two synovial joints are involved. At that time, we can easily diagnose that case as a case of rheumatoid arthritis. So, this is the summary for diagnosis of rheumatoid arthritis. Thank you to all.